Welcome to this explainer. Today we're tackling something incredibly important. We are demystifying epilepsy. And we're not just going to memorize a laundry list of symptoms and drugs. We're going to build a logical first principles framework. Because honestly, once you understand the actual mechanics of what's happening inside the brain, the rest of this topic just clicks right into place.
Picture this. You've got patient A. Their arm is jerking rhythmically for about 30 seconds, but they're totally aware. They can actually describe exactly what's happening to them in real time. Now, contrast that with patient B. They just stare blankly for 10 seconds and then seamlessly finish the sentence they were speaking with absolutely zero memory of that gap. Now, both of these patients are having seizures, but here is the fascinating part. Biologically speaking, they are experiencing the exact same underlying electrical event. The only thing that differs is where in the brain that event starts and how far it spreads.
So, here is our roadmap for decoding this mystery. We're going to start with the core storm, break down the brand new 2025 classification, map out the anatomical geography, apply the diagnostic filter, dive into a massive emergency trap, and finally wrap up with our long-term strategy. Let's jump in.
Section 1. The core storm. Synchronized excess.
First things first, we've got to clearly separate two terms that get confused all the time: a seizure and epilepsy. Normally, your brain's cortical activity is this beautiful, asynchronous hum, kind of like a busy city street. Everyone's doing their own thing, firing at different times for different reasons. A seizure is what happens when a critical mass of those neurons abandon that normal diversity and forms a hypersynchronous flash mob. They just start firing in uncontrolled lockstep. But it's a transient event. It comes and goes. Epilepsy, on the other hand, is the chronic predisposition to having these recurrent, unprovoked seizures. So if someone has a single seizure because of alcohol withdrawal or a super high fever, they aren't necessarily epileptic. Epilepsy means there's an enduring, underlying brain abnormality that keeps generating these storms.
Moving right along to Section 2, the 2025 classification and its updated terminology.
We actually need to update our vocabulary here because the International League Against Epilepsy just revised their standards for 2025, and this shift dramatically improves our clinical precision. We are officially moving away from the old 2017 framework. For starters, the word onset has been dropped. We just say focal now instead of focal onset, which honestly just cleans things up. But the absolute game changer here is that the word awareness has been replaced by consciousness. And this isn't just administrative trivia, it is absolutely crucial. Because consciousness is now defined by both awareness and responsiveness. Think about it. A patient might be perfectly aware of their surroundings during a seizure, but literally frozen, unable to respond. The old framework totally missed that nuance. The 2025 update hits the nail right on the head. So this new framework cleanly divides these electrical storms based on their geographic starting point. Focal seizures arise from a network limited to just one hemisphere of the brain, and they can either retain consciousness or impair it. Now, if that focal seizure spreads to involve both hemispheres, it evolves into a bilateral tonic-clonic seizure. Generalized seizures, however, are a different beast. They arise within and rapidly engage bilaterally distributed networks right from the very start.
Section 3. Anatomical geography. Because when it comes to seizures, location is everything.
This is where the first principles logic really shines. Seizure presentations aren't arbitrary at all. They are direct maps of brain anatomy. Let's look at the frontal lobe. A storm here classically produces motor activity, sometimes really bizarre hyperkinetic movements, and they often cluster during sleep. Move over to the temporal lobe, which, by the way, is the most common focal epilepsy type in adults. Here, you're going to see an aura, maybe an intense, unexplained fear or déjà vu, followed by impaired consciousness with automaticisms. Think lip smacking or fumbling hands. If the storm hits the occipital lobe, the patient experiences visual phenomena, like flashing lights. And the parietal lobe, that gives you sensory symptoms, like weird tingling or distorted perception of your own body. It is pure geographic logic.
But wait a second. What about those brief, blank staring spells we saw in patient B earlier? Well, those are generalized absence seizures, and they reflect a fundamentally different mechanism. They're driven by a bilaterally synchronous thalamocortical circuit, so a really deep central loop in the brain. They've got an abrupt onset and offset, there's no aura, and absolutely no post-seizure confusion. Because they aren't a focal process spreading slowly across the cortex, they look and behave entirely differently from a focal seizure.
All right, Section 4, the diagnostic filter. Let's talk about finding the actual cause.
The underlying causes of seizures span a really massive spectrum. You've got structural lesions like tumors or prior strokes. You've got metabolic issues like hyponatremia, which is low blood sodium.
There are infectious causes, genetic syndromes, and we're increasingly recognizing autoimmune encephalitis as a highly treatable cause, especially if you're seeing personality or memory changes. But here's the trick. The most important tool you have is actually the age filter. If you have an older adult presenting with a brand new onset seizure, your primary suspects should heavily skew towards structural and vascular causes, simply because underlying brain lesions are just so much more common in that age bracket.
To actually pin down these causes, we rely on two main diagnostic pillars. First up is the EEG, which captures the brain's electrical signature. We're looking for interictal epileptiform discharges, basically the abnormal little electrical sparks that happen between the actual seizures. But here's the catch. A single normal EEG absolutely does not exclude epilepsy, because those discharges are often hiding between seizures. The second pillar is the MRI of the brain, which is non-negotiable for identifying structural causes, like hippocampal sclerosis or a tumor. And if you're still genuinely scratching your head, video EEG monitoring, where you capture the physical event on camera alongside the brainwaves, becomes your ultimate diagnostic tiebreaker.
Section 5. The emergency trap. This is where time dictates absolutely everything. We need to talk about status epilepticus. It is a true high-stakes neurological emergency, and it follows a strict time-anchored sequence. At 0 minutes, the status is developing. By 5 minutes of convulsive seizure activity, or 10 minutes if it's non-convulsive, it is considered officially established. If that seizure continues despite 2 adequately dosed medications from completely different classes, you are now in refractory territory. And if it persists beyond 24 hours despite being on anesthetic-level treatment, that is super refractory status.
So, that begs a really important question. Why do our first-line emergency treatments fail so frequently in these critical moments?
The answer is right here, and it's something you must avoid. It's the benzodiazepine trap. Our first-line treatment is a benzodiazepine, like lorazepam or midazolam, but recent audit data shows a pretty terrifying reality in hospitals: widespread systemic underdosing. Only a small minority of patients are actually getting an adequate first dose. And this is a massive trap, because inadequate dosing directly causes progressive drug resistance. You are actually making the seizure aggressively harder to stop the longer it drags on. The golden rule here is simple. An adequate, full dose given promptly is always better than cautious, incremental baby steps.
Now, if you fall into that trap, or if the first line just flat out fails, you have roughly 30 minutes to pivot to your second-line agents. The landmark ESET trial looked at 3 major intravenous drugs here: levetiracetam, valproate, and fosphenytoin. And the result? They have equal efficacy. There's literally no significant difference in how well they stop the seizure. Which is great news, because it means you can freely select your second-line agent based on the individual patient in front of you, their comorbidities, their other meds, or honestly, just what you have physically available in the pharmacy.
If that second line fails, we are in deep water. We enter refractory territory. Third-line treatment requires moving to the ICU and starting anesthetic infusions like propofol. But here is the vital detail. You must use continuous EEG monitoring at this stage. You have to definitively prove the electrical storm has stopped, because subclinical seizures can actually keep firing away even after the patient stops physically convulsing. Interestingly, there's also some really cool emerging evidence for ketamine in super-refractory cases. It hits a distinct NMDA receptor mechanism, giving you a totally new angle of attack when the standard therapies just aren't cutting it.
Finally, Section 6, Long-Term Strategy. Let's talk about managing this condition outside of the emergency room.
Long-term management perfectly echoes that anatomical logic we built earlier. You have to match the drug to the specific seizure type. Generalized epilepsies tend to respond best to broad-spectrum agents, think valproate or levetiracetam. Focal epilepsies, however, respond beautifully to more targeted sodium channel agents like carbamazepine. And I want to highlight a really empowering point here. For drug-resistant focal epilepsy, where there's a clear, localized origin, resective epilepsy surgery remains a highly underused, yet incredibly viable option. We shouldn't just endlessly cycle through medication combinations when a definitive targeted solution might be right there on the table.
So, the next time you encounter this, I want you to ask yourself a few logical questions. Where exactly did the storm start? How far did it spread? And, if you're in an emergency scenario, is the clock working against you? The human brain is a delicate electrical grid, and every single second counts. Will you be ready when the storm strikes? Thank you so much for joining me in this explainer, and keep learning.